And I've been working with Nicholas for almost 10 years. And I think, honestly, Nicholas is going to be changing the cancer field with his knowledge of how to quantify collagens in the circulation. Who's teaching who? I mean, Nicholas told me some years ago that there are more cancer-associated fibroblasts than cancer cells in some diseases, and we need to look into those. And I think what we are learning today is really that we can do much better with cancer patients, and we can do that with a simple blood sample. So, Nicholas, I cannot wait to hear what you are going to tell us. So, thank you very much for taking your time to join us and give a presentation.
Thank you very much, Morten, for the nice introduction. So first of all, I want to thank everybody for joining in today. I think it's super exciting that we can spend the morning or afternoon talking about extracellular metrics. And I will focus on the cancer part of extracellular metrics, in particular how collagens and tumor fibrosis deactivate the immune system. It blocks access to tumor, form this fibrotic cap. It's associated with poor prognosis and immunotherapy resistance. And of course, I will talk about how we can potentially quantify some of this serologically and what we can potentially use that for. I want to start by acknowledge all the centers and institutions that we have been collaborating with all the many years that we have looking into the matrix, and also my colleagues at Nordic, obviously, for contributing to everyday discussions. So thank you there as well. I want to start in the helicopter perspective. I want to start by simply stating that there is a major medical need in cancer, being that far from all patients respond to the treatment that they are giving. If we start on the left here, I've made a general survival curve, which reflect what we often see on traditional chemo and targeted therapies, being that there seems to be good initial response, but over time we have a drop in survival, and we see survival curves that looks like this with limited long-term benefit. And then, of course, with the introduction of immunotherapy in the recent decade or decade and a half, checkpoint inhibitors, we have witnessed all of a sudden that there's a fraction of patients that seems to have long-term benefit of treatment, which is, of course, super encouraging and something that the field is trying to build on. And actually, Cancer Research Org published last year, I think it was, that there are actually now more than 550 targets being investigated for immunotherapy in the cancer setting, close to 5,000 agents being tested in the clinical setting. That's quite impressive. I think the most predominant and successful one to date is probably anti-PD-1, anti-PD-L1 monoclonals, which basically activate T cells to eradicate and kill the tumor cells. And PD-L1 and PD-1 antibodies is also currently being tested in combination with many different other modalities, as this figure down here shows, to potentially try to push up the fraction of patients benefiting from the immuno-oncology approach that seems so promising. What I will focus on today is what I hope will be the sentence for tomorrow. It's basically how we can, by thinking of cancer as a fibrotic disease, hopefully begin to see survival curves that looks more like this, at least for a subgroup of patients that I will come back to. I will start by basically defining tumor fibrosis. It's also known as Desmoplasia. It has its own word in cancer. I don't think it's that different from general organ fibrosis. It's defined by increased extracellular matrix remodeling and collagen production. It's basically a restructuring of the connective tissue, adjacent to the tumor cells. I like to think of it as sort of its chronic active scarring process. So I think it's important that it's active, it's an ongoing activity, also for later discussion. If we look here down to the left, the bottom, I have included a slide from a pancreas cancer tumor where you can see the tumor elements in dark color, and you can see the sort of desmoplastic reaction in lighter color. And there's actually much more desmoplasia in the tumor microenvironment of a pancreas cancer compared to the actual tumor elements. Also what I've been trying to tell Morten, as he mentioned. And if we look at on the left side, here we have a representative staining based on trichrome for total collagen content across different solid tumor types, again showing that there's a lot of collagen deposited in the tumor microenvironment, not only in pancreas cancer, but also in many other solid tumor types, a lot of tumor fibrosis, a lot of collagen. If we then take sort of a jump into the tumor microenvironment with a focus on the tumor extracellular matrix, we have for a long time been studying the basement membrane, the specialized extracellular matrix that underlies the epithelial and endothelial cells that sort of, in a healthy condition, support cellular polarity. And we have also seen, and known for many years by Mina Bissell and others, that the context of the epithelial cells and the tumor cells matters, and the basement membrane is part of this. And it's also why the basement membrane has been most extensively studied in the context of tumor cells and their invasive phenotype. What we are seeing now, and what is equally important, is of course interstitial matrix, the matrix that is part of the tumor stroma, the matrix that is associated with cancer-associated fibroblast and tumor fibrosis. And I will talk primarily on that today. When we look at it from a ECM collagen perspective, being a collagen geek also, I think it's super interesting that we have specific collagens defined to the basement membrane, type 4 collagen, type 8 collagen. These collagens can then be used to say something of basement membrane turnover related to the tumor cells and invasion potentially. Then we have other types of collagen, the interstitial matrix in the underlying stroma that associated with cancer-associated fibroblasts and the tumor fibrosis. And lastly, we have the interface here where we have type 6 collagen and type 7 and type 8 collagen, some of the facet collagens that sort of connects these two compartments and tells their own individual story as well. So by looking at different collagens, actually, we can tell something about the tissue remodeling confined to different compartments of the tumor microenvironment. It's also important to understand and reflect on that, again, and this is something that is dynamic. So if we look at a healthy tissue here in the middle, there's a very nice balanced turnover of old proteins and synthesis of new proteins. A balanced remodeling of the extracellular matrix is sort of maintain tissue integrity. If we look in the context of tumorigenesis and the tumor microenvironment, we see severe fibrolysis, but also increased fibrogenesis. We have overactivation of cancer-associated fibroblasts driving tumor fibrosis, and we have chronic inflammation and other things driving fibrolysis. So we have a high tissue turnover disease. And as these reflect different mechanisms, it's important that we can also separate formation and degradation of the tissue, of the collagens, to understand the full picture of these processes. And that is what we are doing based on blood biomarkers here at Nordic and in my group, looking into specific collagen fragments that are released into the blood based on these fibrolysis and fibrogenesis processes that potentially can be used, quantified by immunoassays and used to reflect the biology going on in tumor microenvironment. Hope you can follow that. just as one example from pancreas cancer published with Penn State a few years ago, we shown here 3 biomarkers related to collagen turnover. We have fibrolysis and fibrogenesis. We have type 3 collagen degradation and type 4 collagen degradation, and we have type 3 collagen formation, PRO-C3. And I think you can appreciate that comparing to the dotted line, which is the healthy reference range levels, there are significantly elevated levels of collagen degradation and collagen formation fragments in serum from pancreas cancer patients. A lot of tissue remodeling. I also want to mention that these can actually also provide some quite unique value. And if you were available for Morten's talk, he also showed you this. I want to state it again because it's important. So by looking at different collagen fragments, we can actually provide some additional value as to just looking at the total collagen or any given particular collagen. So actually here on the right side, we have one type 4 collagen fragment that is generated by granzyme B cleavage to reflect T-cell infiltration. And we see that patients with high levels of this C4G biomarker at baseline survive better on EP treatment in metastatic melanoma compared to those with low levels. In contrast, looking at another type 4 collagen fragment, one that is generated by MMPs, we know MMPs are related to tumor aggressiveness. We can see that high levels is associated with death, basically. So 2 different biomarkers from type 4 collagen actually provide complete opposite prognostic value in this setting here. Again, supporting that the turnover of these fragments of the collagen is clearly important. I want to talk about cancer-associated fibroblasts. Cancer-associated fibroblasts are the major driver of tumor fibrosis. They are also being quite extensively studied in the field at the moment. We are beginning to understand that there are different subtypes of fibroblasts and that they mean different things. In our team, we have also established a model so that we can actually culture fibroblasts in vitro, normal fibroblasts and cancer-associated fibroblasts from pancreas. And then we can evaluate what is the impact on potential pro-fibrotics or anti-fibrotics in terms of activation and proliferation of fibroblasts and in terms of the extracellular matrix deposition and therefore also the tumor fibrosis. And I just want to show a relatively simple example for that. In the middle here, we are looking at normal fibroblasts and cancer-associated fibroblasts. The readout is PRO-C3, which is basically a quantification of the propeptide of type 3 collagen that is cleaved off when collagen type 3 is synthesized and assembled in a tissue. So it's a measure of collagen synthesis and fibrosis. And we can see here on the bottom that normal fibroblasts have relatively low levels of collagen synthesis, whereas cancer-associated fibroblasts intrinsically have very high levels of PRO-C3 synthesis, meaning that they are fibrotic. And what is also really interesting is that when we add an anti-fibrotic, in this case an anti-TGF-beta, to these cells, to these cancer-associated fibroblasts, we can basically normalize their fibrotic activity, at least based on PRO-C3 readouts, to that found in normal, otherwise healthy fibroblasts. So it's basically a simple model system to evaluate potential anti-fibrotic effects on cancer-associated fibroblasts. And by applying our biomarkers, these can, of course, then be applied in the clinical setting afterwards. Just as an example here on the right side, we have looked in a relatively large cohort of pancreas cancer patients based on the BioPAC cohort, a subgroup of that, where we can see PRO-C3 is highly elevated in panc compared to benign, but also that is very prognostic for outcomes. So if you have high PRO-C3, high fibrotic activity, you also have worse overall survival than if you have low PRO-C3 on a standard of care chemo, and as illustrated here. And I know I've been focused a lot on pancreas cancer, but it's actually a phenomenon that we see across many different solid tumor types, actually all the different solid tumor types where we look. And we have published on breast, pancreas, melanoma, colorectal, and hepatocellular carcinoma over the last couple of years. And the coming, here I'm focusing on PRO-C3 as it was basically a hypothesis-driven approach to see if we could find a signature related to fibrosis for predicting overall survival. And I think we can say that that was definitely the case. Patients that presented with high PRO-C3 at baseline all have worse overall survival outcome. PRO-C3 predict for 2 to 3-fold increased risk of dying by dichotomizing cutoff across these different solid tumor types, across these different modalities that they have been treated with, clearly stating to me that yes, cancer is a fibrotic disease, it affects survival, and it's something we should take very seriously going forward. If you like a graphic illustration, as I do, you can basically think of it as tumor fibrosis forming this sort of fibrotic cap, change in the extracellular matrix compartment that leads to poor drug uptake and poor infiltration of T cells, change in the immune component that all affect the responsiveness to various anti-cancer therapies. I've shown you that clearly tumor fibrosis is prognostic, and we can use some of our biomarkers exemplified by PRO-C3 to find this phenotype. But we can actually use also some of these fibroblast-derived collagens, PRO-C3, type 3 collagen turnover, to also predict response to stromal modifiers. And I've included this example that we did together with Halozyme that just got published, was it last month or the months before that, reflecting on this. So here we have the phase 2 trial of PEG-PS20 tested in metastatic pancreas cancer patients, where one arm was receiving PEG-PS20 as an add-on to standard of care chemo versus chemo alone. And I should mention that PEG-PS20 is basically a hyaluronidase, so it's the great hyaluronin acid in the tumor microenvironment. Hyaluronin is also sort of an extracellular matrix component that accumulates a lot of water and leads to increased interstitial pressure in the tumor microenvironment. So if you could potentially move this, you could increase the drug uptake of the chemotherapy. That was sort of the rationale for this. Halozyme did a tissue biopsy staining for HA to see if they could find a subgroup of patients with improved response to PEG-PS20. And we went in also with a liquid biopsy, measuring type 3 collagen turnover to potentially do the same, but in blood. And the rationale here was that type 3 collagen and HA is overexpressed in the tumor tissue concomitantly, basically. So here is the summary of the findings. I should mention we did quite a robust cutoff testing, discovery validation cohort back and forth. So this is the summary slide comparing a tissue biopsy to the liquid biopsy of type 3 collagen turnover. If we start on the top left here, you can see that the tissue biopsy, looking in matched patients, so the patients that both have a biopsy evaluation and a blood sample evaluation, there were really no predictive value. Looking at the HA content in the tumor tissue, there was no really favor of PEG-PS20 add-on to chemo compared to chemo alone. In contrast, with the C3 and PRO-C3 ratio, a fraction of patients with a biomarker high signature, there was a clear, significant benefit of adding PEG-PS20 to chemotherapy compared to chemo alone. And we did not see this in the biomarker low subgroup of patients. So we can actually predict response to a stromal modifier based on a liquid, looking at the fibroblast-derived collagens. And the turnover of this. I think I'm relatively proud of that. And I think, yeah, so what is also really interesting on the same line of thinking is that when we divided the group, the patients into those that were HA low and those that were HA high based on the biopsy measure, we actually saw that the liquid could provide predictive value in both subgroup of patients, meaning that by looking at the turnover of the collagen, looking at the turnover of the matrix, provide some unique and additive value to a more static measure that you typically better obtain with a biopsy. Super interesting data. So to sum up here on the first part of my talk, tumor fibrosis, I think it's fair to say that cancer is a fibrotic disease. We see increased collagen and extracellular matrix deposition and remodeling. It's important that it's a dynamic process. We have degradation and formation of collagens. The actual fibrosis is driven in particular by TGF-beta pathways, but also other related pathways. Obviously, that actually the cancer-associated fibroblasts, these are very fibrotic. They need to be controlled, I think. We also see that when we look at the fibrotic activity is associated with poor prognosis for patients. I've shown examples with PROC3, and also shown you that we can actually also predict response to stromal modifiers and potentially use that for future combination approaches. So all in all, very encouraging data, I would say. And I want to move this forward into the context of immuno-oncology, where I started off by saying that there's a lot of research, clinical research going on, obviously. I think most of you know that. Can we use some of these fibrosis measures in this context? And I want to start with this really nice simple figure published by David Nato or Yang a few years ago, simply stating the impact of a fibrotic ECM on immune cell function. If you look at poorly fibrotic tumors, where you don't have a severe fibrotic component, of course you have low collagen deposition, but you also have a normal T cell infiltration, you have cytotoxic surveillance, and you have what we call potentially good macrophages, M1 phenotype. So all in all, a good condition for response to checkpoint inhibitors and T cell engagers and other immune modulators. Whereas in fibrotic tumors, you have, of course, you have the increased collagen deposition, but you also have exclusion of T cells. You have reduced T cell infiltration. You also have immune suppressive cells and a hypoxic environment, all in all, leading to lower chance of benefiting from immunotherapies. And this basically comes down to two things, as I see it: immune exclusion and immune suppression. I think there's been published some really interesting data in the immune exclusion space over the last recent years, and with some very nice pictures along with it. So I want to also take this here. If we look at an immune phenotype, immune inflamed phenotype here, we can clearly see that the CD8 T cells, which of course needs to be present in order to respond to immune therapy, is also what we call a hot tumor. We can see that in a truly inflamed tumor, we have an overlap between the tumor compartments and CD8 T cells, whereas in the excluded phenotype, we can clearly see that the CD8 T cells sort of are trapped, if you like, in the stromal compartment and do not reach the actual tumor cells. This is also associated with sort of a cold tumor because you don't have the tumor in the right compartment. So this is more likely to lead to a non-response and progression on IO treatments. Supporting this, Sanjay Mariathesan showed in bladder and a few years ago also that the T cells are actually sort of trapped in this collagenous matrix in the tumor microenvironment in the immune excluded phenotype. And this leads to lack of response to anti-PD-L1. And again, this was further associated with a signature of TGF-beta signaling and fibroblast activity in good line with what I've also shown you previously. And then finally, I wanted to show you this very beautiful picture down here from Peransoni a few years ago now, actually, also showing you how CD3, so T cells, are localizing together with the matrix, the fibronectin stainings, and not found overlapping with the tumor cells in blue here. So immune exclusion is really an important phenomenon for understanding lack of response to immunotherapy. And this, of course, led us to also investigate if we could use our fibrotic signature, our biomarkers related to this, to also find those not benefiting from treatment, basically, potentially having this excluded phenotype. I want to show you one example, but based on 3 independent cohorts from the metastatic melanoma space. We have a cohort treated with EP, a cohort treated with Nivo, and a cohort treated with Pembro, so 3 different checkpoint inhibitors. And in all cases, what we saw basically was that tumor fibrosis, here exemplified by PRO-C3, measured at baseline, high levels is associated with poor overall survival across these different 3 different cohorts, supporting that tumor fibrosis, PRO-C3 associated with checkpoint inhibitor resistance. And that, of course, the next question is, what can we do about it? So clearly, tumor fibrosis, immune exclusion is one side of the coin. The other side of the coin is, of course, immune inflammation. And can we do smart thing to find immune inflamed phenotypes, potentially monitor this from the periphery? That would be really nice, and that encourages us to develop this C4G biomarker that we've spent some years on actually developing. It is developed to reflect or quantify type 4 collagen degraded by granzyme B. It was shown in Cell a few years ago that T cells specifically use granzyme B to degrade type 4 collagen in the basement membrane when they infiltrate the tumor here. So C4G is reflecting granzyme B degraded type 4 collagen and therefore T cell infiltration. And actually, when we combine both of these sides of the coin, so tumor fibrosis and T cell infiltration based on C4G and PRO-C3 measures, those patients that have high C4G and low PRO-C3 have benefit from treatment, whereas the patients with an excluded phenotype, which we defined as C4G low or PRO-C3 high, are dying. So by looking and combining different collagen measures, I think that's the take-home message here, reflecting different biology, we get some additional value and some good informative segregation of patients at baseline. I want just to say also that others have looked into extracellular matrix remodeling and fibrosis in metastatic melanoma, and also find a similar signature as we have, namely that, and in this case, an transcriptional signature related to genes involved in extracellular matrix remodeling, also associated with non-response to anti-PD-1, basically, just supporting what I've shown you on the previous slides. I will also mention that it's also something that we see in the IO context beyond melanoma, obviously. Moving forward into immune suppression, and in particular focusing on the interaction with collagen, of course, I have to talk about LIA1. So immune exclusion is one thing. I think immune suppression is a slightly different thing, but of course they interact and overlap. And I think LIA1 is getting more traction these days. And LIA1 is basically an immune suppressive collagen receptor that is expressed on T cells in the tumor microenvironment. And upon interaction with collagens, it leads to T cell exhaustion, basically. There's a soluble form of LIA2, which is of LIA1, which is LIA2, which can potentially prevent this LIA1 collagen interaction from happening, and therefore you will have T cell activation. It has recently been published in Nature Communication also that collagens directly promotes PD-L1 resistance, and that it acts through the LAIR1 CD8 positive T cell exhaustion I've just told you here. And you can see just as a picture here down as an example that if you treat with both LAIR2 and anti-PD-L1, this is where you also get the largest infiltration of CD8 T cells supporting this statement. So I'm super excited to see that they're actually focusing on trying to prevent this LAIR1 collagen interaction. And one example is NC410, which is in development by Nexure, which is basically a LAIR2 FC protein that works in similar fashion as LAIR2, so preventing this interaction here. It has been shown preclinically to increase T cell infiltration and granzyme B activity. And we have actually also been able to measure some of biomarkers in the preclinical setting in this collaboration with Ines Ramos, a postdoc in Linda Mayer's lab. And what we found very interestingly was that in mice treated with NC410, and we actually saw an increase in C4G compared to untreated mice. And it's worth mentioning that this increase, first of all, it happened only in treated mice and not in untreated mice, but it also happened at time of tumor eradication. So it actually sums up very nicely, I think, supporting not only that NC410 is doing something with T cells and granzyme B activity, but also that is related to tumor eradication. Super exciting data. To finish off, we have a continuously effort striving for assays related to IO and tumor fibrosis. I think we need to really try to understand tolerogenic and immunogenic phenotypes in greater detail. One approach that we are taking is focusing on some of the fibroblasts, obviously. We have a type 11 collagen formation biomarker that is potentially highly associated with cancer-associated fibroblast activity, but we have also seen related to poor response to anti-PD-1. Another interesting biomarker that I want to highlight is it's related directly to neutrophil activity. Neutrophils are also getting a lot of traction these days. We have this biomarker CPA9-H&E that actually reflect neutrophil extracellular traps, which we know directly shield off tumor cells from cytotoxic attacks. And I think it's interesting that we can now also quantify this non-invasively. And when we do so, it supports what we would expect, that high levels of NETs give you a poor chance of benefiting from anti-PD-1 treatment. Really nice data here. So I just want to finish off by asking this rhetorical question, if you like, that should we treat cancer as a fibrotic disease? I strongly believe that we should do so. And I've taken the liberty to add tumor fibrosis therapy as the next big innovative step in this very nice figure published showing you what have happened over the years of cancer treatments. So to sum up, I think it's important that we implement cancer as a fibrotic disease. We now, I think, have some tools to identify patients with high fibrotic activity that clearly responds poorly to current treatments. The next thing would be to develop or potentially repurpose antifibrotics for these patients, and most likely in combinations. And by doing so, I would encourage, obviously, that we take into account potential changes to the extracellular matrix, remodeling, formation, degradation, tissue turnover, what's the fibroblast activity, what's the fibrotic changes, how is the inflammatory aspect impacted, and how can we potentially address T cell activity. Turning cold tumors hot is clearly a good match here as I see it. So yeah, thanks for listening in.